All right. Okay, we're going to be talking about irritability and challenging behavior. You can go to the next slide, Laura. So the objectives we're going to try to cover today are going to be to really review some of those potential causes of irritability and agitation or aggression in children and adolescents diagnosed with autism. We're going to talk about some treatment options and the role that medication plays as a part of that treatment option. Next. And so anytime I use a term like irritability or aggression, I think about how little that means if we're not also discussing what that looks like or what it means to that family. As a clinician, I hear lots of terms, thrown out that parents are seeing. I am a pediatrician, so I do see children and adolescents for the most part. But I will often hear terms like, well, he's so irritable, or she's very frustrated or aggressive or agitated. Sometimes you'll hear tantrums or meltdowns, interfering behavior, shutdown. And I think that what I try to view it as, whatever the family uses, I will often mirror their language and say, okay, you're seeing agitation. What does this agitation look like, for example? But you'll often see these things kind of thrown around interchangeably and find that different words may mean different things to different people. A story that I'll tell that kind of gives us the reviews kind of the importance of getting to the bottom of these terms is a mom that I see. She's amazing. I love working with her. I've been with her for about a year now. She has a 3-year-old son with autism in preschool. And she sees me and also one of my psychology colleagues. And to both of us at our last visits with her, she said, I'm so mad that the school just keeps telling me how aggressive he is. He just started preschool and I keep hearing he's aggressive. We have this app where I get behavior reports and it always says he was aggressive today or there was aggression today. Just doesn't mean anything to me. It's not describing what the behavior looks like and it's not actionable. I can't do anything about it if I don't know what it looks like or what caused it to happen. And I just thought, knowing that this was a conversation, I think 2 weeks ago, and knowing that this talk was coming up, I was like, yeah, that's a really great way to frame this, that we often, even though you'll hear me say irritability and aggression a lot because, that's what's on the labeling indication for some of the medications from the FDA and in the literature that we use. Truly, it doesn't mean much unless you're giving actionable information that's descriptive in nature. Next. And so how would we try to define irritability in a concise way? Well, there was an article that looked at this. I think this was actually even from 2006, so quite a time ago if you think about it, but they defined irritability in individuals with autism as these vocal or motoric outbursts. We've changed the term to bursts here, which I think Maddie's going to share some information with us about in a moment, of anger, frustration, or distress that can be associated with acts of physical aggression towards self or others, sometimes resulting in property destruction or harm of another sort, and could be seen in up to 30% of children who have autism. And so when they looked more closely at that 30%, parents were kind of defining it a little differently. So about a quarter of them saying it looked like physical aggression, about 30% of them were saying severe meltdowns, and 16% some self-injurious behaviors. And so we see that this can be a problem. And I do want to pause just a moment to allow, Maddie to relay some important information about kind of changing this terminology in our kind of lexicon to more bursts versus outbursts.
Thank you, Lindsay. One of the things that I've found in my advocacy and in working with my kids, as well as working with professionals and all of the myriad amount of people that work with our kids, when we change our language to things like, for example, we change outbursts to bursts, we change the connotation, we change the feeling, we change the energy that word has from a negative to a neutral, and it also changes the perspective that we have in our kids. Another example is changing a tantrum to a meltdown. A meltdown, we acknowledge that the kids don't have the control in the moment to be able to deal with this, whereas tantrums tend to be connotated that there's some intent behind it, or they could stop it if they wanted to. And when we reframe and rephrase these words, it allows us, when we're looking at our own kids, to see the need they have instead of the behavior that they're doing. And these are just two words right now out of a multitude of words that we can use to move away from a lot of the medical jargon that we've been given about the disorder part of autism, and we can look at how we can support our kids that are in front of us.
Yeah, thank you so much, Maddie. Such important information. And that's why I'm so lucky to be a part of this group. All right, next. And so this next couple slides just review some of the reasons that we believe or have found that children with autism are more likely to experience symptoms of irritability. We know that there's an increased risk for having more stereotyped or repetitive motor mannerisms, and sometimes those mannerisms in and of themselves can cause some injury. That insistence on sameness and routines that, when disrupted, might make you feel frustrated or irritable. Highly restricted or focused interest, again, not really wanting to be disrupted in any way, which can increase some of that irritability. And then hyperreactivity to sensory input. So thinking about, loud sounds, really strong smells, being in an overwhelming, crowded situation. Next. We also know that there are difficulties in that social communication and that understanding relationships and emotional reciprocity, or that back and forth, which means that, children with autism are more likely to struggle to communicate their needs. They may become easily frustrated and overloaded when all these sensory inputs are coming in, and then have a decreased understanding of how their actions may impact other people. Right, next. And so why is this a problem? I think we all know, we're all here for some reason. We have a loved one or a child perhaps, or we take care of patients or other, that we have seen this be a problem, at times. Sometimes it's physical harm. Sometimes it's physical harm or property destruction. Sometimes we see that these behaviors might start to jeopardize opportunities for educational or recreational placements. I have a young adult who's in his second year of college who's stepping back because of how hard it is for him right now. And we're trying to problem solve. How do we work through this? Because absolutely, we want him to reach that goal of obtaining that degree. Psychiatric hospitalization rates can be increased when we have these higher rates of aggressive or irritable behaviors, increases risk of residential placement, and certainly increases family stress. Recently a friend of mine was talking with me about her young child that happens to have autism, and she and her husband made a very difficult decision to live apart from each other so they could take turns with the caretaking, because no one was sleeping, and other stressors that were involved. And so these are things that we certainly want to be able to address, and we want to be able to get people back to their optimal functional level. Next. All righty. And so as a developmental behavioral pediatrician, working with families, it's valuable to me to know which of my patients are going to be more at risk for having some of these behavioral concerns. And so certainly we know and I think Amy did add the article that we got this from to the resources slide, but we know that kiddos who have more complex needs and more extensive needs, medical needs, social needs, more severe intellectual disability, additional mental health, neurobehavioral or psychiatric diagnoses are all, these are all things that put you more at risk for more challenging behaviors. And then also all of this is impacted by biological, familial, developmental, and social factors as well. And what's so important about recognizing this risk is so that we can know, ooh, I really want to monitor you extra closely, or you as a family, if you find yourself in this position, know, maybe I should bring this up to our care team, that we want to be able to kind of catch this head on or early in the process. Next. All right. This is a slide that I believe, I stole a couple slides. I'm not going to lie. I think this one I may have stolen from Dr. Bitter's talk earlier, talking about evaluating a child with irritability and aggression, and really starting with identifying the behavior and the components of that behavior. Hopefully, most of you guys were able to attend his excellent talk about the behavioral interventions for behavioral concerns in individuals with autism. We did split this up into a medical and a behavioral lecture, although that was mostly just for time's sake, so that we could deliver these on 2 separate dates. However, I think we would all agree that it is never just medical interventions or just behavioral interventions. And so I just put this slide in as a reminder to myself that even though I'm going to be talking a whole lot about the medical piece of it, that doesn't mean that I'm not ever recommending the behavioral interventions. In fact, that is almost always a part of the recommendation. And so when we look at a behavior, we're asking often questions that allow us to better understand if behaviors B, the antecedent, or what happens before that behavior, is an A. So is there something that ended up causing that, right? If it's a kid who has hyperreactivity to loud sounds, is that maybe, are we noticing he's in these crowded environments right before the behavior occurs, for example? And then also looking at the consequences, or what happens after the behavior. How do we respond to that behavior? How do others respond to that behavior? And how can understanding the antecedents and the consequences of the behavior help us with our intervention? All right, next. This is a slide I added after talking a little more with Amy. I think one thing that I am hoping that you'll be able to take from this is, gosh, well, what can I do to maybe help my team, my medical team, my other team members understand, what it is we're really seeing at home? Because often when I'm indicated a visit, if it's a 30, 45-minute visit, I'm getting that 30, 45-minute snapshot every so many months, right? So I don't know what this might look like to you on a daily basis. And so some things like maybe having some descriptors about, what does this behavior look like? Describe it to your team, kind of paint that picture for them. This is what he does. This is how it starts. This is how long it lasts. Is there anything that makes it better? Is there anything that makes it worse? Are there safety concerns, that lets us, how quickly do we need to really escalate this? Was this a gradual shift, or was it a sudden onset? It certainly makes me think of different things in my brain when I'm hearing, well, it started about 5 days ago and it's been really bad ever since, versus hearing, yeah, I think it was probably about a year ago and it's just been kind of building slowly since it first started about a year ago. Those mean different things in my mind. If you're able to anticipate it, how are you able to anticipate it? And then how long does it last? If I forget to ask that question, which I've done before, sometimes I think they're describing something that's a 5-10 minute episode. And then when we talk more about it, I'm like, oh, wait a minute, that was 2 hours. And, this is really quite a lengthy thing that has been getting significantly worse. And don't be afraid to share these concerns. That's what your team is there for. Sometimes when I worry that there might be more than a family is sharing for a variety of reasons, I will try to ask the question, I'm glad everything's been going well, but what was the hardest day you had since last time we met? I think that's also something Amy taught me, right? So if you can describe to me your hardest day and give me more information about that, that might help me also kind of get a better sense of how things are going. Next. This is a real busy slide that I don't anticipate you guys will be reading. It is less important that you know every box on this slide, but more so this is really just to say, when we're first having this discussion about irritable or aggressive behaviors, for example, we really want to prioritize specific treatments, and that's only able to be done after we consider all the potential contributors. And so those potential contributors are those 5A through 5E. We're going to talk about those in a little bit more detail specifically. So I won't, make you read those in these tiny boxes, but we'll just go ahead and move on to the next slide. Alrighty. And so most importantly, and the one I'll spend the most time on, is considering the medical factors that may be contributing. Amanda's case highlighted this very perfectly, right? I think that it's hard to treat an ear infection with Risperdal, as we have found out. That was a hospitalization that probably didn't need to happen. And that is really, one of the bad case scenarios. But it's a box that's unfortunately kind of easy, I think, to fall into. There's this term called diagnostic overshadowing, where when there's a diagnosis already at play, you tend to try to want to blame everything on that diagnosis. So it was easy to say that this kid with autism was having these irritable behaviors, and well, it must be his autism, and so let's do the Risperdal. Well, maybe it's the side effect of the Risperdal, and so then you kind of get the snowball effect, right? And so what we try hard to avoid that diagnostic overshadowing, which I think is another thing Amanda said. We're like, ooh, we really need to go back. Has anybody done a head to toe physical on this kid, right? And you guys even, were putting that into the chat already. One of my favorite stories, I was in medical school in Southern West Virginia. I was raised in Southern West Virginia in a very, very rural location. And my favorite doc I ever worked with as a med student was very rural country doc. And he just had glowing recommendations. Every time I'd see a patient of his, they would say, oh man, he's the best. He's the best listener. He listens to us. He listens. And we were talking about that at the end of the rotation. And he was like, if I can give you one piece of advice, here it is. I had a family come in. The mom, this was an adult mom with her adult son, would come in. She had severe anxiety, often was coming in and really just needed reassurance, but often was coming in up to twice a week. And at one point, the son said, look, I think there's something really wrong. I know she's crazy, doc, but she could have cancer too, right? And so it became this kind of lightning bolt, I guess, in his mind, to just be like, oh, yeah, maybe I should do some more extensive workup. And he did. And she had a very significant diagnosis that hadn't been caught before. And he said, you know what, you can't, and even though we wouldn't use the term crazy in our practice, right? That term crazy and cancer too stuck in his head. Like, you know what, it doesn't matter if you have anxiety. It doesn't matter if you have diabetes. It doesn't matter if you have autism, whatever your diagnosis is. There can be something else that's causing these medical concerns. And it isn't fair to just brush everything off and say it's because of the autism. And so that's what I think we try to do in practice. And there's a very random assortment, or appears to be a random assortment, of medical problems. They're listed underneath that. Those are just some things in the past few months that either I or my colleagues have been able to identify in some of our patients presenting with behavioral problems. So as you can see, quite the variety there that were not just innately due to their autism diagnosis. Next. Okay. Additionally, some of the other contributing factors to consider is the difficulty using functional communication, and just remembering that behavior is a method of communication. And so we do want to acknowledge that. Any significant psychosocial stressors, we want to make sure we're also recognizing and acknowledging, providing supports if needed. And that would be, has there been a recent divorce, a loss of a pet, anything that could fall into that category. This term of maladaptive reinforcements, I think this article was really just trying to highlight, is there a pattern of behaviors that we're seeing for a specific reason? We all have learned behaviors, right? I show up to work because I've learned I get a paycheck when I do it. If you're really wanting to avoid bedtime, then you're going to probably, if you know, hey, mom always lets me have extra time on the tablet, if I engage in this type of behavior, then that's another type of reinforcement. Co-occurring mental health or neurodevelopmental conditions like ADHD or anxiety. I know Amanda, Lisa already did some great talks on those things previously, but just keeping in our mind, anything like that that is untreated, we would want to treat first before we just treat irritability. Next. All right, again, this is just the bottom of that algorithm. Nothing specific for you guys to necessarily read on this slide. I put it there as a reminder that, hey, we've gone through this algorithm, we've looked at all of those contributing things, and now here we are considering pharmacologic or medical treatment for this irritability that we're seeing, because we've ruled everything else out. Next. And what's most important is really thinking when we're starting this process of prescribing a medication that you as the family are there and have the most important seat at the table. So we can prescribe medications to help manage irritability, and the parents, caregivers, other therapists, everybody is important co-managers of that treatment, meaning it's most helpful to me if I'm getting feedback from all of you, but most especially family. Next. And this slide is just a reminder. This one I stole from Dr. Ratliff Schaub, who was one of my mentors. A reminder that there isn't a skill in a pill. There's no pill I can give you that will teach you those skills that you need to kind of move on to that next priority that you have or goal that you have. But I can often use medication to target some specific symptoms and help improve functioning so that maybe you are better able to participate in a therapy, for example. Next. Okay, a couple of medication options out there. What we most commonly use, what I'll be spending my time, the remaining time talking about mostly, will be the medications that are alpha-2 agonists. That's one category, and atypical antipsychotics. That's another category. We're not going to talk much about some of those less commonly used medications. I do want to, where you can go on to the next slide. I do want to take a little bit of time before we talk about those medications to just talk about what off-label medication use means. You heard me say earlier that only 2 medications have been FDA indicated to be used for irritability and aggression in individuals with autism. Off-label use, however, is extremely common in pediatrics, meaning there's not that FDA indication. A couple of reasons for this are the ethical considerations in pediatric research. As you can imagine, that's something we're much more careful with than in adults. And then that lack of financial incentive for pharmaceutical industries. And I think all of us here at this table would say that's not a good reason to not do the studies in pediatric patients. However, you've also heard money does tend to talk in these situations. I think the good news is that it's been more increasingly recognized as an important public health issue for kids. And there's been several legislation changes over the last 15 or so years, really seeking to improve that we have more kind of indicated FDA drugs for our pediatric population. Just kind of also keeping in mind that that's often a decades-long process to really get through the work. So for now, we extrapolate from the data that we have. Next. The American Academy of Pediatrics has actually has a policy statement on label use of medications, and really just saying that the purpose is there for the benefit of the patient if you choose to use something off-label. Off-label doesn't imply that it's improper, illegal, contraindicated, or investigational, and that what's most important when you're deciding on the best treatment for the child that you're in care of is evidence. Evidence, not the label indication, is the gold standard. All right, next. So we're going to talk first a little bit about alpha-2 agonists. These medications are known as clonidine and guanfacine. You may have heard Tenex, which is the short-acting version of guanfacine. Intunib is the long-acting version. And then clonidine also has a long-acting called Capvey, and the short-acting is Catapres, you may have heard. There are some studies, mostly in ADHD, but that show symptomatic improvement in impulsive behavior, hyperactivity, explosiveness, and stereotypies or repetitive behaviors in children with autism and ADHD. But that explosive piece is what we're kind of looking at here today. That's how some people may choose to explain some of those behaviors. For the side effect, the first side effect, and perhaps one of the most common ones that we see, would be some sedation, which makes you kind of drowsy or sleepy. Clonidine is much more likely to cause that and often can be used just to treat sleep problems, especially trouble falling asleep in kids with autism or ADHD. I think it was Maddie's idea to highlight irritability in red, which I think was a great idea, because here we are treating irritability, and one of the potential side effects is worsened irritability. It isn't a super common side effect I tend to see, but I have. And when I've seen it, it's been pretty clear that it started right after the medication, and that would be a reason to certainly stop it. One of the ones I talk about most at length with families is that blood pressure change possibility. Clonidine especially is used for blood pressure management in adults or adult-sized people. And it can therefore cause blood pressure to go low. In young kiddos especially, this can be a concern. We had a kid not long ago within our hospital system who got into her brother's clonidine and accidentally, well, took it, I think, probably thinking it was candy. She was pretty young and couldn't tell us, but she was, they weren't able to wake her up and ended up having to be in the hospital for a couple of days. So very important that it's a medication that's stored, the lid is on tight and in a way that, in a place that no one could access it. And then constipation is one of the other common side effects that we'll see. I think that this is a medication that we often go to first line because it is, even though we've talked about these side effects, it is often very well tolerated. And even though it isn't FDA indicated, it is often used with the support of data. So we do have data to support that it helps. Often used first line, because when we think about it compared to the atypical antipsychotics that we're getting ready to review, that side effect and safety profile is certainly a little bit better. All right, next. So atypical antipsychotics, there's a list of these. I'm talking about two specifically today. So risperidone, which is the brand is Risperdal, and then aripiprazole, which is Abilify. We're specifically highlighting these two because they are the two that you will tend to hear the most about, since they are the ones that have been studied the most and have the FDA indication. They are medications that, for the right kids, can be a great choice. But you do have to talk about the potential safety concerns and side effects. There have been some large trials that have demonstrated some nice improvement. So if you look at that first bullet point, 69% of parents said much improved, 12% said very much improved on the irritability subscores on this rating form that was used. Also helpful in some other, symptoms of repetitive behaviors and hyperactivity. Next. And so it can truly be a great option. I will say I had a family once say, I want to relabel this rescue doll instead of Risperdal because it just rescued us. But as we were looking at the potential side effects here and talk through them a little bit more, you'll see why we want to spend a little bit of extra time, maybe counseling before we start it, because it does come along with several monitoring or several pieces that we want to monitor ongoing. Although it isn't on this list, I must have left it off. It also can cause irritability. And so I would just like to highlight that, because even though it's not on there, I have seen it cause irritability, and I've had people stop it because they have gotten more irritable, although it hasn't been something I've seen super commonly. The drowsiness you can also see with the atypical antipsychotic. Some patients will develop symptoms of drooling. There are some significant metabolic effects that can happen. And when I say metabolic effects, I mean specifically things like gaining weight, having increased risk for elevated cholesterol levels, triglycerides, that would be those dyslipidemias, elevated blood glucose, which is our blood sugar. Those things are important to catch because we don't want to have you have an increased risk for cardiovascular problems as you get older, like when you think of high cholesterol. And then the weight gain and elevated blood sugar certainly can increase that risk for diabetes. And so we want to be very thoughtful about those things. Elevated prolactin can also happen. You may have heard about this, development of breast tissue or leaking breast milk, which is called galactorrhea. That can happen. This prolactin is a hormone that our brains make that is best known for allowing us to produce breast milk. Comes in very handy when you're trying to feed a baby, not as handy, when you're a 13-year-old boy in school, right? And then extrapyramidal symptoms, which is really a whole host of different kind of movement or neurological symptoms that you can have. Tardive dyskinesia, one in particular, we really monitor closely for these. You'll see these kind of sudden uncontrollable movements, and we really monitor for that at every visit where we see kids on these medications, because that's something that would require a change in the medication or the dose of the medication, because we know that it could potentially become long-term or permanent. All right, next. Alrighty. The atypical antipsychotics, though, can be quite helpful in situations where you're not seeing enough improvement with other interventions that you've tried. There are significant safety concerns. You're unable to implement lower risk interventions. And just know that it does require that monitoring. And so we're watching closely when we're starting these medications. Next. And I wanted to highlight that more with this table because it's saying the same thing that said in text, but just if you're like me and you like visual better, these are the labs, the glucose and lipid that you would get at the initiation of the medication, and then recommended at 3 months, 6 months, and annually, as long as everything is okay. And then the BMI is really looking at your growth rate. You're taking your weight and height into consideration and tracking that to make sure it's not going up too quickly on this medication. In addition to those things, we'd also be doing some type of monitoring for those abnormal movements. Okay, next. Alrighty. Like I said, some less common options that I'm not going to spend a lot of time talking about, because these are medications that maybe if you've tried all other things and they're not working, are potentially used. There's not as much evidence. They may be limited to really small studies. Not a lot of data there, but something that sometimes, especially our psychiatry colleagues, may sometimes prescribe. So you may have heard these words sometimes thrown around in the treatment of irritability. Okay, next. One word of caution, it is sometimes easy to get into this phase of adding additional medications, right? I think both as a medical provider, especially, I can see this happening sometimes where, okay, we're already on 4 medications, now I'm adding a 5th. It doesn't mean that that's always inappropriate. Sometimes it is. However, anytime we're using lots of medications at the same time, certainly increases the risk of having side effects and can potentially enhance or inhibit the metabolism of other medicines you're on. That would just be important to know, because that might mean you would need to adjust the doses of other medicines you're on. And since we're not often studying all these medications together at one time, there can be unknown effects. And so I think for you, if you're finding yourself in this situation where you're considering adding another medication to your regimen, it is certainly fair to ask for a medication interaction analysis from your medical provider. All right, next. This is really just reviewing again what Amy said earlier, how important it is that you guys are keeping in mind those target behaviors and goals, that you're monitoring that and sharing that going forward and being a part of the team. This may not have come across super clear in the resource toolkits that are at the end of this, and also in your box file. They have different types of charts that you can consider using. Your doctor's office may have ones that they prefer. But consider using the same one each time so you can really follow those behaviors over time. Okay, next. And then how are some ways that you as a family are able to help support that medical prescribing? And so certainly expect adjustments based on what you're observing. Why else would we tell you to keep these behavior charts and track the data if it's not going to be used to help with the prescribing? Get the labs when expected, or what I will often tell my patients, I at least want to be working on this as a goal. If I cannot get your labs and I still feel like it's in your best interest to start a medicine that requires labs, what I will usually do then is try to work with the therapists that are working with your family already on making that a goal to be able to draw those labs. Be clear as a family on what your expected outcomes are. What are your goals? How do those goals shift over time? And help avoid clinical inertia, which is when we might stop a therapy or not start a new therapy or not go up on a dose just because, you know, we feel like things are a little bit better, if there's still room to go to really meet those goals. And then eliciting discussions of decreasing or discontinuing medication treatments. It's always fair and important to look every so often and say, okay, hey, we've been on this for a while, this same regimen for a while, for example. If things are going well or we're stable, or things aren't and this regimen's not working, what can we maybe consider stopping or decreasing? Because the goal would be to be on the least amount of medications and the lowest doses as possible for what you as an individual need. All right, next. And so these are just an example of some of the toolkits you'll have access to. There's several of them that I think go along with this talk. Next. Okay. Oh, where is, sorry, next. Yeah, we might be glitchy again, sorry. And then the additional resources will be included as well. I believe I'll defer to Amy or whoever else is next. I believe that it is time for questions if no one else, unless we had polls or something.